Hi everyone, how are you? My name's Jess. I'm the alumni coordinator here for the University of Pittsburgh. Thank you all so much for coming. We're super excited to have all these speakers here and have you join us and also get continuing education credits. So let me see if I can figure out how to use this. There we go. So just a quick disclosure before I go into introductions. There is no potential conflict of interest or financial interest by the faculty or planners of this activity. There is no commercial support of this activity, no endorsement by the University of Pittsburgh or ANCC of any commercial products discussed, displayed in conjunction with this educational activity. The entire session and the participant feedback tool must be completed to earn contact hours. So if you signed up front or if you forgot, you can do so after the event. Just initial next to your name, we'll contact you and get your CE credits for you. Awesome, now that we have that done, I'll give this to Helene. So just want to introduce our speakers for you today. So Helene Burns here is going to be our keynote speaker. Helene is the Chief Nurse Executive for Jefferson Health in New Jersey. She began this role in 2013 and led her organization to receive Magnet designation in August of 2018. Helene is accountable and responsible for patient care services and nursing operations in Jefferson Health, New Jersey hospitals at Cherry Hill, Stratford, and Washington Township. Helene has more than 35 years of experience in the healthcare industry, so we'll definitely love her knowledge today. She received her doctorate of nursing practice in health systems, executive leadership from the University of Pittsburgh in 2018. And then we have Salina Smialek Torgerson. She is a senior professional staff nurse and a 2016 graduate of the University of Pittsburgh School of Nursing. In her current position, she works as a bedside nurse at McGee Women's Hospital here in Pittsburgh in the adult ICU, caring for critically ill patients with a wide variety of diagnosis. At McGee, she is also a member of the Unit-Based Staffing and Retention Committee, as well as a Magnet champion in the hospital-wide Magnet Committee. Outside of the hospital, Salina remains active in the Pitt School of Nursing at the Governance Chair of Sigma National Honor Society ADA chapter. And then third, we have Saira Ramasar. She is currently a student at the Pitt School of Nursing in the Accelerated Second Degree BSN program, graduating in 2 weeks. So I'm sure she's excited, as most people are that are getting ready to graduate. So she actually received her first degree here from the University of Pittsburgh in emergency medicine. She worked as a paramedic for almost 5 years prior to going back to nursing school. So we are super excited to hear everyone's perspective on healthy work environments, and I will let Helene take over.
Great. Thank you. Can you hear me okay? Okay, so just want to take a little bit of a poll. Who are the students? Anybody students? Alumni? Okay. My hand's up too. So welcome, so welcome. So I have to tell you that I am just beyond delighted to have been offered this opportunity to come and speak to all of you. My experience at Pitt was nothing but delightful. I loved Pitt. And, you know, it really was a wonderful program for me. And, you know, I have 35 years experience, actually 38 this year. And I graduated in 1981, went back to Widener University, which is in the Philadelphia area. Went back and got my master's again at Widener. And I really thought about doing the Triple Crown, right, and doing it at Widener again. And what steered me away from them and towards Pitt was your program. It was really all about your program, what you offered, and that for me, being a chief nurse, that it was totally online. Because I don't know which day I'm going to be early, late, you know, every week is different, so I needed something very, very flexible to me. So 4 a.m. was my favorite time to study, okay? But, you know, you got to do what you've got to do. So I have been, a little bit about me, I have been in New Jersey and the Pennsylvania area most of my career, although I did spend some time in the Dallas area and up in Nashua, New Hampshire. So I finally figured out that the only thing that changes is climate. Otherwise, nursing is really all the same. We all have staffing issues, we all have joint commission and whatever else there is. So I came back to the Philadelphia area probably over 15 years ago, almost 20 years ago now, and I have been working with what was Kennedy for now 11 years, and we became part of the Jefferson Health System probably about, it was 2 years ago. So now we're part of a large health system. We have 14 hospitals. You may know the name Thomas Jefferson University. That is our flagship hospital, but we have now 14 hospitals and continuing to grow because we hear there will be more mergers, every day. So it's really different to be now merged into a large health system. It was so much easier to get things done, but you're learning to swim in the new place. In New Jersey, for us. We have a home care agency. We have about 600 beds. There's about 4,900 employees. And of that, there's almost 2,000 nurses who worked for me in New Jersey. These are our accolades in New Jersey. These are our hospitals. But the one that I love the most is sitting right in the middle, and that's called Magnet. And that's the one I'm most proud of. When I took over as the chief nurse for our system 6 years ago, our CEO said, "What do you want?" And I said, "I want Magnet." And so we took the journey, and it was wonderful. And finishing school and going through the Magnet journey, and right after school, so I graduated in May, and we had our site visit in June. So as you can imagine, once we got the notice in August, I did take a deep breath and a vacation. But yeah, it's been a wonderful ride. So, I actually did my DMP project on healthy work environment. And so I've had the opportunity to read a lot about it and learn a lot about it. And I will tell you that I believe that as we talk today about healthy work environment, it really did start back when a group of nurse scientists got together and started this research project and said, what is it about hospitals that attract nurses and patients also are attracted to it? What are the qualities of that? That was the basis of what became Magnet. And those Magnet standards, those early Magnet standards, which now have evolved over the years, core to that is talking about a healthy work environment. So what exactly is a healthy work environment? Well, it's one that's really safe. And what do I mean by safe? Well, it's safe for the patients, that there's no harm to patients, or there's minimal harm. We're chasing zero all the time for harm. But it's also safe for nurses, that it's a good place for them to work, and they feel safe when they're taking care of their patients. It's empowering, and the G got to the end, I like that, but it's empowering. And what do I mean about that? That you have a say in what happens, and how you make your nursing unit better through things like shared governance and unit councils. It's satisfying. There is nothing better than driving home and feeling good. And there's nothing worse than driving home and not feeling good. But that feeling of, I did a really great job today. I really helped somebody, or I helped several people. So that's a healthy work environment, very satisfying. Good working relationships, I apologize for this being a little bit off, but good working relationships, and that's not only about doctor-nurse relationships, that's everybody's relationship. There are still bullies out there, and they're still in nursing, and that's not a good work environment. So for us, that's really important. Shared decision making, what do I mean about that? Well, I always say that what I love about shared governance the most is I'm not making decisions. There are very few decisions I make anymore because most of our decisions are made in councils, and most of our councils are chaired by clinical nurses. Wow, how important is that? How impactful is that? So that's what I mean about shared decisions. And then attentive and responsive to concerns. When a nurse picks up a phone and says, I have a problem, I have a concern, I have an issue, whether that's a safety hotline or even just saying to a manager, a director, anybody out of a nurse leader, myself, I have a problem, I have a concern, and we listen and we work on it to make it better, and you know, life's not perfect, but when you work on it to make it better, that becomes what I call a healthy work environment. So I really believe, and the literature says healthy work environment is critical to patient safety. It's intertwined. If you have a good working environment, if you have appropriate staffing, if you have the resources that you need, if you have the ratios that you need, you're going to take good care of that patient and keep that patient safe. Also, it's integral in attracting and retaining, retaining the nursing staff. When the environment's good, you don't leave. You know, when the environment's not good, you leave. And then are developed and fostered through CNOs. I really believe that the role of the chief nurse is to provide that leadership on a healthy work environment. If I'm not paying attention to what's happening out there on nursing units, who has high turnover? Why do they have high turnover? And we were talking about it. Sometimes high turnover in ICUs today is all about people going back to school. They want to be NPs. They want to be CRNAs. But if there's a high turnover in a nursing unit and they're leaving because of the work environment, that becomes really a problem. So what does it require? So members of the team have to have good working relationships. And I always say that's from the top down. And you know, my relationship with the medical staff is modeled by my nursing staff. And so if I don't have a good relationship with the medical staff, and I make sure that I let my nurses know that, you know, we don't care for those doctors, or, you know, I say something very inappropriate or sly, how do you think the nursing staff will feel about the patients? So, you know, the chief medical officer and I both have this very clear path that we talk about, that we are always side by side on everything. We may not always agree on everything, but we're always side by side on it, because that's how I want the nursing staff to feel, side by side with the physicians. Clinical nurses are involved in decision making. You know, it's really interesting. Nurses sometimes say, I'm not involved in decision making. Well, yes, you are. You know, when you call the doctor up and you say, that patient's very, very sick, or let's say that they're very nauseous, and they're post-op, and you say, you know, they need something. And the doctor says, well, what do you think? And the nurse tells them, well, they need Zofran, or whatever that is. That's what's called shared decision making, isn't it? You have helped that physician, obviously, and helped that patient. The organization listens and responds to patient care issues or concerns identified by clinical nurses. You know, I think that's very important, that we listen, that we hear. We do it through a number of different venues. We can do it through surveys. We can do it through walking rounds, stopping and talking, being there at unit-based councils or wherever, and hearing what the issues are. That makes part of a healthy work environment, because we know then what to work on. But when these things are not there, that's when we really do see an unhealthy work environment. So, what contributes to a nurse feeling dissatisfied? Lack of advancement. And advancement can be going from one type of unit to another. That's a little bit more complex for you. It could be a ladder program where you're moving up, but you're staying within. It could be advancement into a leadership role. But when you don't have those advances, that gets you dissatisfied. Lack of educational support. The patient ratios and the skill mix. You know, it is really important. Sometimes people will say, well, let's not talk about that. But it is really important to talk about. You know, my job is to make sure that the ratios that are budgeted are appropriate. My job is to go to the table every year and say, this is what I want. I have the luxury of having a great finance group, because they say to me, as they just, so we're starting our budget cycle, they actually said to me, Helene, write out what exactly you want and come back and tell us. So med-surg is a 5-to-1 ratio with a charge nurse without an assignment. You know, for me, intermediate care is a 3-to-1 ratio with charge nurses without an assignment. And then critical care you know, it's really not 2-to-1 because it has to be better than that, because oftentimes we have patients who need a 1-to-1. So, you know, to have a medical staff and a administrative staff who are supportive of me saying, this is what I need, and this is how we will deliver good nursing care. You know, cost containment efforts, and I apologize for these, I should have looked at them right before. They looked good on my computer. Cost containment efforts. You know, when we make like really dumb decisions, right? Like, let's get the cheapest IV pump, right? And that cost containment effort has now caused that bedside nurse a miserable time. You know, the IV tubings don't fit, the cassettes don't fit right, you know, all the problems that you could have when you're doing cost containment for the reasons of not involving clinical staff. Because we can do cost containment efforts, but we have to involve the right people at the table to make those decisions. Problem relationships, and this says with physicians. You know, that it really is important, we have to listen to that. You know, it is difficult, particularly if you're a new nurse, to understand how to do that, how to talk to doctors, but that's why we're here as more experienced nurses, because we can help you with that. And then finally, leadership issues like visibility. You know, I know there's a problem on a nursing unit when the nurses say to me, we don't see our nurse manager. We don't know where our nurse manager is. Our nurse manager doesn't come out and help us when it's really busy. You know, that lack of visibility speaks volumes, doesn't it? So all of those things, combination of those things will contribute to that nurse dissatisfaction. When I was putting my project together, it was a very interesting time for me. I am part of the Organization of Nurse Leaders, ONL, which is part of AONE. This is the state chapter in New Jersey. It's ONL New Jersey. There is a group of us, and I'm on the board, and a group of us had a really great conversation about what was happening in our state, because we have been seeing this ratio bill keep coming. It keeps coming up the legislative and going back down and coming back up and going back down. And what they wrote is very, very similar to California. Now, the funny story is that the author of that bill was from one of the towns that one of my hospitals was in. So he asked to talk to me and the CEO. And he left with his tail wagging because he had no idea what he was talking about. He had no clue at all. And as I explained to him what the bill would do and what has happened in California, because really California is the only state that has mandated ratios for every type of nursing unit. It's been since 2004. Why has it taken since 2004 and nobody else has done it? Because the literature says it's not good. It has not improved patient outcomes nor nurse satisfaction, nor has it been the financial improvements to organizations. And the literature is very clear on that. So we all got together and we started to talk about, do we have, you know, how do we want to do this as a group, and how do we want to move forward as chief nurses in the state? And I said to the group, well, at my staffing council, because I have a staffing council which I chair, me and primarily clinical nurses, I said, the funniest thing is an OB nurse brought this article for me to read, for us to read. And here she had brought the American Association of Critical Care Nurses 6 Essentials for Standards for a Healthy Work Environment. And I just got a kick out of an OB nurse, night nurse, finding this article and saying, this is a really good article about healthy work environment. So I took this to the chief nurses in the state. We actually did a research project that we have just completed in our state. It actually is published this month in Nurse Leader. Dr. Mary Johansson is the primary author of that. We participated in that research study. That work is now being done throughout the whole state. Many other hospitals are now, we don't have staffing councils, we have healthy work environment and staffing councils. And we do education in the state on it, and I just love that the model for this came from my nurse. So this is the model that we're using in the state. Here's the 6 essentials: skilled communication, true collaboration, effective decision making, appropriate staffing, meaningful recognition, and authentic leadership. And when you read this essentials, it really is, it's a combination of all of this. It's just not one thing, but it's really a combination of things that really do make that healthy work environment. So I want to talk a little bit, moving on to talking about turnover, new to practice nurses, and the healthy work environment. So I don't know if you know this, but here's what the statistics say, and I got this from the National Advisory Board. The median bedside nurse turnover rate has continued to rise since 2010. It was about 8.7%. This is their most recent data. So greater than 12% in 2016, and every year it rises more. So our bedside nurses are turning over at rates that continue to rise. That's always a really good question when you're going to work for a hospital, or you're going to, as a new nurse or even an experienced nurse, what's your hospital turnover rate? Sometimes that can tell you a big story. And now let's talk about the millennials. Well, the millennials, to be honest with you, are the largest growing section of our nursing population. As us baby boomers continue to retire, the majority are now in that millennium age. And interesting thing, it used to be a bell-shaped curve where the millenniums were here and the baby boomers were here. As we begin to leave the profession, that will be more of a slope type of a curve, where we'll see many more millenniums. So what do they want? What's satisfying to them in a good work environment? They want advancement quicker. It took me 10 years to go back for my master's, 20 years to go back for my doctorate. You know that many students are in school to go right from a bachelor's to a master's to a doctorate, or some type of an extended career. That's what they want. Their loyalty is different from other generations, and that's not bad. It's just different. They stay less than many of us did. We had to stay for 25 years, whether it was a good place or not. We were going to stay. Millenniums don't. They leave. And that's really okay. They like their time off, which I actually really love. I love that we're actually challenging our own ideas. I had a nurse manager come to me horrified. She had a millennium who actually had the gall to say she wanted to go to Europe for 3 weeks and do backpacking. And the nurse manager said to me, "We can't let that happen." And I said, "Why? Why can't we?" "Well, it doesn't follow our rules." So maybe our rules aren't good. I said, "Think about it. Wouldn't you love to be able to go?" And then I said, "So wait a minute. Do we have nurses who were born in states other than the United States who still have family that they go to see?" And she said, "Oh yeah." I said, "Well, do you grant them?" "Oh yeah." "And do you have a problem with that?" "Oh no." So I said, "Okay, so why would we have a problem with someone wanting to backpack in Europe for 3 weeks?" I said, "If your schedule permits, why not?" So, it's thinking differently. For us in the baby boomer generation, it is a real different thing. They also want financial advancement. They want to go from a bedside nurse to whatever that is, become a CRNA, become an advanced practice nurse. Why? Because of the financials, just as much as the advancement is there interesting. So, in hospitals, how do we retain the nurses in the first year, particularly our millennials today? Hospitals, and this is only since 2014, once again from the advisory board, but 48% of the hospitals had a residency program in 2014. I bet it's probably closer to 60 or 70% at this point. I think a structured residency program makes a lot of sense. It has didactic simulation, just as they have learned in school. It continues that. You know, preceptors, you know, we know that give a nurse a couple of preceptors and they're okay, give them 8 preceptors and they won't have a good experience, right? Cohort debriefing sessions, you know, and we never had this, but what a great value to get people together and talk about what worked, what didn't. They do case studies and that type of thing. And I think that we've only touched in nursing this whole issue of mentorship and career planning. You know, what I really am working on now is mentoring that experienced nurse, finding that new nurse and having that mentorship program. And they may not have been their preceptor, but it's someone that they can grow with in their career. All of those things I think are valuable. So the other thing that I read is 27% turnover first year without a residency goes down to about 18% with a residency. In my residency program, I track 1 and 2 years. I have a 95% retention rate in the first year and about a 90% rate in the second year. They do say, though, with millennials, it's not the first 2 years. We really have to track the first 5 years. Because remember how I said they're more apt to leave? So that tracking, I think, is real important. So what do we need to do beyond that first year? I think for new nurses, that residency program is a solid way of engaging them, of getting them to that healthy work environment. But beyond the first year, how do you build that loyalty? I think it's collegiality for clinical questions, allowing that young nurse to ask hard questions, and having people say, "Oh, that was a dumb question." You don't say that. You know, you help them through that. Social connections for emotional support on and off the shift. That's important for young nurses, and how we do that. At Jefferson, we actually have it's like a Facebook for work, and there's nursing units that they do that social connection whether they're working or not. You know, obviously HIPAA violations and all of that, it really has to be more about building that collegiality. But for the millennial generation, social connection is really important for them. Exposure to different units. You know, that's part of keeping me interested, is let me see what it's like to be an ICU nurse or an ER nurse. And, you know, one of the things that we were talking about doing every year since I started as a chief nurse, I did this because, I'll tell you a real funny story, in my very first board meeting, which scared me. I sat there and my former chief financial officer, who's no longer with me, he stood up and he said to the board, "I don't know what's wrong with Helene. Nurses can take 6 patients around the clock. She doesn't know what she's talking about. They do that in that state that I used to work in, and she's just making a big deal out of nothing." And so, I will tell you that I know of other chief nurses who probably would have verbally accosted him at that point in front of everybody. I chose to say nothing. And I actually went into his office the next day, closed the door, sat down and said, "You will never say anything like that again to a board member about nursing care, and you have no idea what you're talking about." So I will tell you, he never did, and he left, so that was good. But so that very first year, so here's my story. So that very first year, because of him, I decided that the entire seniors team should shadow a nurse for 2 weeks during Nurses Week. So they had to put the scrubs on and they had to follow a nurse. So guess what I did? I sent him to a med-surg unit and we gave that nurse 6 patients and he followed that nurse. So after 2 hours he called me and said, "Helene, I'm really tired." I said, "Dude, you got 10 more hours to go. Don't whine." He never said anything to me again. So the nurses said to me, because they plan Nurses Week at my organization, they said to me next year they want to do a shadowing event where they shadow in different areas. I thought, well, what a great idea. So that exposure to different areas. In one of my households, we've actually done something called walk in each other's shoes, where a nurse, they flip units, like units. So surgery goes to the post-op unit, the inpatient post-op unit, and they spend a shift on the inpatient, and those nurses, and the ER nurses spend on inpatient. It's been really valuable. And I think that's great for communication too. Exposure to nurse leaders. You know, millenniums, all of us, they want to know what's it like to be in your job. Is that something that I could do? So I think exposure to all of us is very important. And really safe environments that you can share your concerns, your fears, and your thoughts of how we make things better. To me, that's how you keep those nurses. And then, as I talked before, developing those strong mentoringship programs. And we're really starting to see that lately in nursing, that you're seeing these good mentorship programs. I think that's something to hook those nurses in beyond. So these are my references, and it has been a pleasure talking to you about a topic that you can tell that I love, because it really, you know, retaining nurses, you know the statistics, the nurse leaves, how much does it cost us, but you know, it's about the reputation. And I want to be the organization where all of the new to practice nurses, they're dying to come to my organization because they know it's going to be a great experience. And to me, that's the right way to do it. So we're going to go to questions afterwards. I am going to hand this one over to Salina, and you're up.
Thank you. That was wonderful.
Thank you.
Thank you. Oh, sorry, that's loud. So my name is Salina Smialek. I was Salina Smialek Torgerson. I just got married.
Yes.
Getting used to that. Thank you. But I was a 2016 graduate of the Pitt School of Nursing. I worked in trauma over at Presby for a couple years in a floor, on a floor unit. So I did the 4 to 6 patients, learned a lot. We also encompassed the toxicology pod, so that was a very backbone building experience to work there. I use those skills every day still, and now I work down at McGee in the adult ICU, which is a better fit for my skill set and kind of what I'm looking for in nursing. I think that your presentation was incredible. I'm really lucky that I work in an environment that kind of does encompass all of those healthy work environment characteristics, and I'm excited to get to talk to you kind of about a bedside nurse perspective on what is important in a work environment that makes you want to go to work every day. So I have had in the past some unhealthy work environment situations, and I think a lot of them related to communication and how you were talking about leadership being the front line is so important. Like when we see our leadership not working together, that trickles down the whole way through. And at some point, I worked at a community hospital before I became a nurse. And when a few key people on the unit decide that they don't want to work there, it trickles to everybody else. So in those situations, it's really hard because nobody is happy coming to work. So I've been very fortunate in the UPMC system to have a lot of support and leaders that want to come to work, and that has made me want to go to work as well. I think the other thing that I wanted to touch on before we go to panel questions that has been really important for me as a nurse is that I feel like I'm heard. Whenever I went into my interview for the adult ICU, my unit director was very clear that she was going to be present. She has a pulse on the unit. She rounds on all of us monthly, which she held true to. I work weekend nights, and she has come in twice at like 2 o'clock in the morning to see me and to talk to me. And she does help us advance up the ladder. So the UPMC system has a career ladder for nurses, and she is always asking, well, what's your project going to be on? What's the next project? Who can I connect you with? Where can you shadow? And on our unit, I think only like 2 people aren't in school or doing a senior professional too, and it's very inspiring to get to work with these nurses who are going on to be nurse practitioners or CRNAs or have been a really good bedside nurse for 30 years and take every student that they can. So that has created an environment where I want to go to work every day, and also that our leadership helps us in what's important to us. So we work with a high proportion of cancer patients on my unit, which can be really emotionally distressing, because if they're in the ICU, that means that something is not going right. And we deal with a lot of end-of-life discussions and a lot of palliative care. And we're fortunate to have support, but my unit director is not shy of reaching out and saying, here's life solutions, here's a place that you can go to get the support you need. Or if we say our patient needs something, we're making it happen, whether it's getting their dog in to see them in those last days and hours, or we just had a breast cancer patient who's very young, and all she wanted to do was have a sleepover with her kids. So we got a second hospital bed and we put them together, and we all brought in, my unit director went out to Giant Eagle in Shadyside, got popcorn, got candy, got movies, and we brought in this big TV and we had a movie night. And unfortunately she did pass a couple days later, but that was her final wish. She just wanted that time with her family. And my leadership made that happen, because if I had to have 4 patients that night, or been run thin, I wouldn't have gotten the time to support her and her 3 children. And we had to get approval from our administration also, because you can't have 3 kids stay in an ICU overnight, or dogs in the ICU. Like, these are not things that usually happen.
Yes, you can.
Well, and that's the answer, that we need our leadership to be open and to say, you're good at what you do, and I'm gonna help you be good at what you do. And it has made me want to be a bedside nurse for longer. I actually was in a program to advance my career, and I'm taking a step back because working somewhere that is so positive with so many people who want to be there, I feel completely fulfilled right now. And it was hard to take that step to say I'm going to stop taking classes and I'm going to focus on climbing the career ladder where I'm at, but I can't see a way that where I'm at now isn't going to add to whatever that next step is. So that's pretty much my thoughts on a healthy work environment. I'm really excited to be here. Thank you guys for coming.
Hi guys, I'm Syra. So as she said, I'm graduating in 2 weeks. It's really exciting and nerve-wracking at the same time. So my thoughts on a healthy work environment are, so my background's in pre-hospital care. My mom was also a nurse, so I grew up around nurses. She worked for too many years, I'm not allowed to say the number, but a lot of years. So I grew up around this field, and it wasn't a joke that I grew up in a hospital. Like, my babysitters picked me up all the time from them. So I've always witnessed stuff like this, and just seeing like the progression. I know we just talked about like millennials, so both of us are millennials, and the way that we view the work environment is slightly different than how the generations before us did. But I also see there's lots of similarities. Like, you want to work somewhere forever. Like, I don't want to move every 2 years. I don't want to be at a different unit all the time. Like, I do want to find somewhere where I can be there forever, or even if it's staying within one hospital system for 20 plus years. Like, I would love that, just to build that. And talking about nurse residencies and ladders and things like that, these are all things I've asked on interviews, or I've tried to make sure to, understand, to see like, okay, what is your hospital's goal to get me to stay? And what are you gonna do to make sure that I'm happy and that I want to work here, or that your patients are happy, or that things are safe? So from my prior work experience, working as a paramedic, I always wanted to know okay, what's happening to my patient moving forward, and building that relationship with the nurses, with the doctors, everywhere, kind of translated that, and seeing those turnovers and why things weren't going the way they were. One of the biggest things for turnovers is patient safety is the biggest one, and then it's just not being satisfied. We've all worked with that nurse or that doctor who you walk in and they just have the worst attitude and this big giant cloud over them, and it just makes your day worse because they're not happy, then they make the patient not happy, they make you not happy, and I've always been sure to watch that even through clinicals. It makes so much, it makes so much more of a difference when you see someone who loves their job. And like Salina said, like finding that unit that you're really fit on, like that's what I'm looking forward to. So interviewing has been really interesting for me because I'm trying to explore more than just emergency medicine and find all the different paths in nursing that I can find. And it is really interesting because there's so much out there. Like I didn't realize how much a nurse could really do. And moving forward, it's like you could go to sales and you could go back and get your DNP and you could be the CNO or the CEO of the hospital. Like there's so many pathways, and I'm really looking forward to this. And I'll take any advice that anyone can give me. So thank you.
So I guess we'll open it up to any questions.
Hi, I wanted to ask about your residency program. Do you have a homegrown residency or do you use the Vizient product?
We have a homegrown, we use the CUSUM model. We are actually looking at the Vizient program across all the 14 hospitals now. Two of our divisions, they were a group of hospitals before, now they're a division. So some of our divisions had it, so that's what we're looking at right now. And one of the things that, well, tomorrow afternoon is an ongoing strategic planning session that we're having as chief nurses, because our vision is for the Jefferson nurse, the standard of Jefferson nursing has to be the same for all of our 14 hospitals and potentially more. And what does that mean? What does that look like? That onboarding of a new nurse, what does that look like? It has to be standard across all, so we're beginning those conversations. So yes, we're looking at the Vizient.
So thank you for your talk. I appreciate your insights. So when I talk to a lot of novice or new nurses, I hear a lot of dissatisfaction and real difficulty with the scheduling around shift work. And I'd be really interested in hearing your insights about it, particularly around also ideas about self-scheduling and what does that mean and how we traded ultimate flexibility for some degree of predictability.
So, I actually wish or hope that we in nursing will get as smart as other professions. So my daughter works in restaurants, and she's 33 and has worked in restaurants since she graduated college. And she's an artist, but she fell into restaurants and loves it. And every time I say something that I think is pretty novel, she'll be like, Mom, hello, we've been doing that. I mean, they have software where they do their scheduling. They do their scheduling off of software, and what I love about them is, they don't call out. They find someone to cover their shift, and they negotiate that, and they do it behind the scenes, and then the manager knows about it afterwards. There's so much flexibility in their business in doing things like that, and she works for a very big, well-known restaurant in the DC area, and so they figured it out. So I think as technology helps us, we'll get better at it. I love self-scheduling, but self-scheduling doesn't mean that we have 12 nurses on one day and 3 nurses on the other. We have to figure out how to even it out. It's never a perfect world. I started on 8-hour shifts. I don't think they're ever going to come back. I really don't. Sometimes I wish they were for continuity of patient care, but I worry about nurses. I think 12 hours is a long time. The literature out there says that it's a long time. Driving home can be like driving drunk when you're very, very tired, and that could be the day shift just as much as the night shift. We actually engaged a company, part of my shared governance. We have a committee called Shift Work Safety, and we have worked with a company and did a train the trainer, and our training is for everybody. And when we talk about shift work safety, it's not, so 12-hour day shift is non-traditional work. It is, and you should go to the class. And they talk about the physiologicals of not getting enough sleep, what that does to you. They talk about drive home and how unsafe that can be sometimes. So, you know, we cover hospitals. We're there 24/7, 365. It's not easy. It's not always easy. And, you know, one of the things that we're talking about is how do you attract back the baby boomers who are tired of working 12-hour shifts? You know, well, what if they work 6-hour shifts? What a novel idea. You know, do we always have to fit 2 6-hour shifts together? No. But you know the busiest time on a nursing unit? Wouldn't it be great if someone came in for 6 hours and just like took that load right? So sometimes it's thinking out of the box, you know, and being creative in how we do that.
And I will say from a bedside nurse perspective, my current unit has a lot of shared governance, and I actually am part of the staffing and retention committee, so we look at that. And with our last group of nurses, many of them graduated to go on to school or to go on to other careers, but they wanted to work a very set schedule, but then we realized the new set of nurses that we had different interests. So now we have requirements for Mondays and Thursdays, but we don't have as many weekend requirements. And it took a long time for us to sit there and to look at all of our numbers from the past 6 months. But when we came up with this new requirement, and then we did our post-survey of if people were satisfied, it went up tremendously because the amount of weekends people had to do went down. And so we still have the same amount of coverage, but based off of just our population, it works for us. So there's not to say that it would work for OB World or the NICU, but for our ICU, that was what they wanted. And to kind of recheck that, we check it twice a year is what our unit director has us do. But I think that's so much more useful than having one clinician in charge of that all the time, and having to make those decisions by him or herself, because people are dissatisfied. But when you have 7 nurses on a council saying, this is what you guys told us and we heard you, then they're more satisfied with that decision. So that has worked for us, but it's always hard. Never closes.
I know that's a concern for me as a new nurse. Like, I interviewed somewhere and they said the requirement in a 6-week period was you had to work every other weekend. Every 2 weeks you rotated day and night. You had to work 3 out of the 6 Fridays, and they had to be at least like this many night shifts, this many day shifts, and just looking at it was really overwhelming. And then it was a high acuity unit, so it was just like, okay, so you're expecting new nurses, old nurses, everyone to just run this type of schedule, also deal with the heaviest of the patients in the entire hospital, and what's the benefit? Like, what do you give in return for that? And she was like, oh, the differential is $1. And I was like, okay. Like, in my head, I was just like, okay, that sounds good. And like, I went home and I just processed it and thought about it. Like, that's how people get burnt out, because you're switching these day, nights. Like, I mean, it's like nursing school. I haven't slept yet. I can't wait to take a nap. And thinking about shift work like that, like I remember doing it as a paramedic or even a tech on the unit. Like, you don't sleep. Rotating day and night is really hard because you're telling your internal clock to, okay, now let's sleep at 8 in the morning and wake up in the middle of the day. The sun is out, by the way, so it's going to try to keep you up. And that's unsafe not only for us as nurses, but for the patients. Like, from doing my transitions, the ICU, I was night shift, and I figured it out. Between 2 and 3 is when your body says go to sleep. It was the most unsafe because we're trying to adjust the ventilator settings and we're giving an antibiotic, and both my preceptor and I just we had all this coffee in our system, but it was just like a switch. Like, we were just tired. But then 7 a.m. came around and we were awake again. And even for day shifts, like, everyone gets burnt out by the end of the day and you're just run down. And I can't even imagine what it's like on a med-surg floor. Like, from all of my clinical experience, like, I've seen numbers like 8 patients is really bad, and that's from having tons of call-offs. And how do you manage someone so you have someone who has trach care every hour and, you know, antibiotics to hang, and these are how mistakes get made. And I think something I'm looking forward to as a new nurse is I want to fix that for the future generations and for the rest of my career. I hope to be a nurse for a very, very long time, and what I want to see out of this is to be satisfied, and not just for me to see the patient satisfied, because it's their safety. Like, we don't want these medication errors. We don't want them to get worse and not better. And we want to, like, I would love to stay in one unit or one hospital forever, so I want to do whatever I can to.
So I, in my organization, we have, my 3 hospitals, we have straight shifts, so you don't rotate. That's such an old world style, like that needs to stop, okay? Read the literature. It says it's really bad for people. We insist that all of our new nurses who come on, whether they work day or night, take our shift class, so they get a sense of what it's like and what they need to pay attention to. The other thing that we've encouraged everyone to do is take that class not for yourself, but also for your family, you know, because there's great tips, and it's a 4-hour class on shift work. And it not only talks about, you know, the circadian rhythm and the physiological and all of that, it talks about eating habits, it talks about, you know, how do you manage your family? How does your family manage you when you have to sleep in the middle of the day? And, you know, how do you do that? So, you know, I think we have to pay attention to those things. It's really important, you know. Having some, you know, one nurse said to one of the administrators, and she was like proud of it, and I said, stop. She was like, I just got this new car, it's great. If I fall asleep on my way home, it'll beep and stop me. And I'm like, that's not a good thing. Okay? What makes you think that's good? Like, that means that you're not getting enough rest, and maybe night shift is not right for you. You know, when you think of people who work night shift and they pretend they're not working night shift during the day because they have children and all of that and all those responsibilities, and then they stay up for ungodly hours, you know, and how safe is that? It's not. So that's my biggest concern.
I was just wondering, Helene, about, I know you were talking earlier about your concern with the 5-year retention rates. I was wondering if you guys have anything where nurses that have been there for a few years can submit a preference to be like all days or all nights. Because I know as a new nurse, it's kind of disheartening talking to nurses that have been there like 2 or 3 years and are really struggling with being on nights. Like, I was just speaking with this nurse last night that had like a miscarriage in the fall, and there's like, I was just reading this article about how there's like increased rates of miscarriages and like with night shifters and all of this stuff about how they don't live as long. I'm sure you guys are familiar with the research. And she can't submit a preference without a note from a doctor, and it's kind of scary thinking about like myself a few years down the line and thinking about these problems as like they seem as future problems now, but that it's something that there's a lot of research about and that like you're constantly aware of. And I was just wondering if you have, because I know we don't have that on my unit anymore, and I think it would be a really good thing.
So if you're a really smart nurse manager, you pay attention to that kind of stuff. If I know I hire you and you really can't cut nights, and you know what, some people just can't. It's not right or wrong, it just is, you know? Not everybody can do it, and if I work with you to be able to get to the shift that you want, and maybe it's not on my unit, oh, maybe I think out of the box and help you get to another unit, because there's a great shift there that you can go to, and you'll be very productive, you know? So, you know, one of the things that we always have to think about is how do you retain nurses? The way you retain nurses is paying attention to what they need, you know? Maybe I can't get you Monday through Friday because I don't have those kind of shifts on my unit, but maybe there's another place that you could work Monday through Friday in a case management kind of a job. There's great jobs like in quality, and there's different avenues for nurses. So not paying attention as a nurse manager is why we burn people out. That's our job. I always thought that was my job. If I knew somebody who got onto a shift that wasn't good for them, you work with them, you help them, you know, you want them to stay. So, you know, we can have all these rules, but really it's about people, and it's about people doing the right thing.
nurse managers scheduling weekly staff meetings instead of monthly and letting us know whenever she had a large board meeting and giving us as much information as she was permitted to and doing it frequently and timely. I just wondered if you had seen anything in the literature about the effect of that and also about how to equip nurse leaders and administrators to kind of incorporate that into practice.
So I really haven't read anything on mergers. I think that was on purpose, right? I don't want to know. But I will tell you that what I've learned very quickly is communication is so key. And you can't ever communicate enough. And, you know, we had a culture clash in New Jersey. We are very, very communication open. You know, everybody knows me by name. You know, it is not unusual for a nurse to email me, call me, and it's not so they can be around their manager. They know me when I walk around. They come up and say hello and talk, you know. So we're a very, very, and my CEO is the exact same way. So we're a very open organization. We went from an organization like that to an organization that made changes and you didn't even know about it until like after it happened to you. Like for example, we all merged our healthcare, and we're thinking, oh, this is great, right? Okay, well, so our out-of-pocket copay is so much more than it ever was before, and nobody told us, and we only figured it out in January, and like we went like, whoa, we would have communicated that like crazy. We in February, we had looked, all the chief nurses had looked at salaries for all their nursing staff, right? So we're in this big room, great big spreadsheet, 14 hospitals, and I have 3. And I could see all my competitors around me too, right? And you can see theirs and theirs and theirs. And we're all looking, and everybody looked at me, and they said, well, what do you do? Because you could see that my rates are totally competitive to everybody in the area. And I looked at them and said, my job? Like, that's my job, to make sure I'm competitive. My best competitor, I'm always like making sure that we're like right where they need to be. So we made very, very little changes. My nurses pretty much got like a cost of living increase because they were exactly where they should be. The other hospitals had huge increases, right? And I'm like, oh great, how am I going to communicate this to my nurses? What are they going to say? Oh, look at them, they got all that money, and look at us, we didn't get anything. So I did what I always did, town halls. So we call them town halls, but it's open, you know, forums. And you know, I had 8 of them, and I probably hit at least 500 nurses. And they all came in, and I said, here's our rates. This is why you're getting your salary increase. You're going to hear that other hospitals are getting a great big salary increase, but let me just explain to you that they've been not getting that money for years. So they're just catching up to you. And the other hospitals, they sent out a letter, and that was their communication. Each nurse got a letter. And I'm like, are you kidding? How do you communicate like that? And so one of the things that I realized, one of my early lessons learned is, I don't have to go by the mold. You know, that's how they do it. And I said, well, good for you. I'm going out and talking to every nurse that I can talk to and explain why we're getting the rates and why they're getting those rates. Do you know that we didn't have one nurse balk, complain, argue, say, you know, throw up a red flag after that? And it's how we communicate it. So yeah, it's hard now. I think one of the things I have the hardest time with is I don't know who to talk to anymore. Like, I'm still trying to figure out, like, who can help me look at salaries. You know, because it used to be I could, like, get an answer in a day. And I could make a salary adjustment for somebody in a day if I needed to. Now, it's like, well, we have to do an analysis. All right? You know, so they're the hard things about merger, but you're absolutely right. Communication is really, really key to make sure that everybody still feels whole. You know, we say that healthcare is delivered locally. No matter how big an organization is, no matter how many mergers they have, healthcare is delivered locally. So you have to think about it that way.
I just wanted to say we're so very proud of all of the folks that are on this panel because you are Pitt alums and soon to be a Pitt alum. And what struck me as I was listening to all of your stories is the importance of leadership. It came through in every one of your conversations. And I recognize that you understand, and I've worked with Salina, and I've worked with Helene, and I hope to work with Syra in the future, the importance of showing up. Showing up not just to work, but showing up and recognizing that, yeah, you do need to get to continuing education programs, and you do need to, as Kaylin, yeah, here, it's like, she comes to events like this to meet other people and to hear what's going on. And so I wondered, Helene, as a question, what you do to foster nurses being involved in their professional organizations, professional development, things like Sigma Theta Tau or AONE.
Yeah, so, we have, I put money in the budget, and, so I went, someone asked me, how do you budget for research? I said, I don't. We pay for it as we need it. And how do you budget for nurses and travel, and how do you budget, how much money do you, so I have this thing, and everyone in the organization knows, it's the inside joke. If you present at a national conference, podium or poster, Helene will pay for you to go. She'll pay your registration. I'll pay, from my budget, I will pay your registration, your travel, and your hotel. Continental US. That's the only thing that I say. Because you can't go to Hawaii without me. But, just saying things like that, encourage people to do that. And you also have to have education, you have to have nurse leaders who say, yeah, you can put a podium or a poster presentation together. No, you've never done a podium before? Well, I have, let's do it together. It's that type of thing that I think really fosters that wanting to be part of. It's really important that we send nurses to national conferences because that's where they get all the great ideas. So, it's actually a fight in surgery, and we have 4 different surgical sites, but it's almost a fight in surgery of who's going to AOR in this year. And they always kind of get creative how they're going to do it so they can get more people to go. But, I just love that they want to go and come back. Part of going and come back is you have to bring something back, and you have to try to implement something. And the value of that is well worth the cost of sending someone to a conference.
I think on the flip side of that, because I see a lot of nurse leaders here, being a somewhat new bedside nurse, it's really important for me to feel connected to my nurse leaders. So like Sigma was huge for me. To have like people who have done it and done it well, and now I know that they're kind of watching out for me or they're in my corner. So if you are in a position of power, it's just so useful to use that. Actually, one of my mentors, Kathy Witzberger, is here in the back, and it was just so nice to see her name on the roster outside because as a brand new nurse at Presby in this overwhelmingly large, very acute hospital, I had someone who I could email and I knew within 24 hours was going to have an answer for me. And Pitt does a really good job of teaching us to use those networking skills, but I've also, I did struggle as a new nurse knowing how do I get involved? What do I do next? And because you're just trying to keep your patients alive and do well with them. So having nurse leaders and having you guys watch for us is huge.
And your involvement is huge too. I mean, as you talked about yourself, I'm involved in my unit council, we're doing this, we're doing that, and as you start, get involved right away, so there was, someone said, I love rumors, there's a rumor that new nurses can't be on councils for like 2 years. I said, who made that rumor? That's not true. It's actually, finish your orientation, then join a council. That's like how I feel about it, and that's what we talk in orientation. Finish your orientation, get on the council, get involved. And that involvement just exposes you to different people, different ideas. It's so much fun to have, a practice council or a quality council. And, you know, on each one of them, there's like 50 or 60 nurses in the room, and I'm the minority. And I love that, you know. And, you know, to hear a nurse from home care talk to a nurse from critical care to maternal child, and they're talking the same language and they're working on the same type of issues, is really very powerful. We had our very first, so we're going to Epic. So Thomas Jefferson University Hospital is Epic. We're going to Epic in September. And they're going to kill me until we get there. I just know it. Because if we have one more meeting, I'm just going to scream. But anyway, so in September we go Epic. And when Thomas Jefferson University went Epic, they built Epic for a single university setting because there wasn't all these mergers. So after they built Epic, all of us started coming in. So we're the second to come in to Epic. And when they showed it to us in New Jersey, I insisted, the first day that they showed it to us, we had a full day session where we could see all the nursing pieces of Epic. We use Siemens Sorian, which is now Cerner Sorian. That's what we use today. And I had invited the other hospitals to our session because I was like, I think we all should be exposed to this. And it became very clear to me early on that practices were different at all the different hospitals. They weren't right or wrong, they were just different. They used different suicide scales, different fall prevention scales. You know, their assessment times were different, lots of difference. And I remember very early on, then we started to see demos of everything, and we involved like the right people in each one of the hospitals, and people started to say, oh, I guess we got to do it by like Thomas Jefferson University does, because, you know, they build it and we have to do it that way. We don't like their scale, whatever that was, right? So I said to the other chief nurses, and we now have a system chief nurse who we just hired, I said, you know what, our opportunity here is to begin an enterprise practice council. So I'm the facilitator of it. We had our very first meeting last week. The room was filled with probably just as many as here today from every single one of our 14 hospitals. It was the coolest day ever because everybody realized in that room that we were going to define practice for Jefferson moving forward. Nobody else was, we were. And how powerful that day was for all of us to realize that, you know, the way that we did it, while that was good, they did it in isolation. They didn't know where they were going to have 14 hospitals at it. And we are all going to decide whether that's the right way for the future. So, you know, I think that when you do things like that, you really involve staff. I mean, people were actually, a couple people couldn't come and they're like, could you just change it? Because I don't want to miss it. Like, no, we have to go, because, you know, but you'll be in the next one. We'll introduce you. So you know, I think that's how you build nursing, and that's how you get people truly engaged. Anything else? Thank you. I have enjoyed being on the panel with both of you. It has been my pleasure. It is so much fun to learn from you and learn from you as you start. I just want to say, you have picked the best profession ever. I'm a little biased, but I love nursing. I still love it after 38 years. And I hope that you both love it as you continue on in your career. So thank you both. Great job.